Okay, so clinical features are effort-related dyspnea is usually dominant symptom, and box 16.77. These are the clinical features of mitral stenosis: breathlessness because of pulmonary congestion and low cardiac output. Edema and ascites, right heart failure, palpitations because of atrial fibrillation, hemoptysis, pulmonary congestion, pulmonary embolism, cough because of pulmonary congestion, chest pain, pulmonary hypertension, thromboembolism, atrial stasis, and atrial fibrillation. What are the signs? Atrial fibrillation because of atrial dilatation, mitral phases because of low cardiac output, auscultation per loud first heart sound because there is pressure gradient across the valve. There is opening snap, there is mid-diastolic murmur, there are crepitations when left heart has failed, pulmonary edema, pleural effusion, right ventricular heave, loud P2 when pulmonary hypertension develops. Okay, typically exercise tolerance diminishes very slowly over many years until the symptoms eventually occur at rest. Patients frequently do not appreciate the extent of their disability until the diagnosis is made and their valve disease is treated. Acute pulmonary edema or pulmonary hypertension can lead to hemoptysis. Fatigue is common symptom due to low cardiac output, and thromboembolism is common complication, especially in the patients with atrial fibrillation. Prior to the advent of the anticoagulant therapy, emboli caused 1/4 of all the deaths. Physical signs of mitral stenosis are often found before symptoms develop, and their recognition is often of particular importance in pregnancy. The forces that open and close the mitral valve increase as left atrial pressure rises. First heart sound S1 is therefore loud and can be palpable, tapping apex beat. An opening snap may be audible and moves closer to the second heart sound. This is opening sound, and this is closer to the A2 and P2. This is loud first heart sound. Okay, as the stenosis becomes more severe and left atrial pressure rises, however, the first heart sound and opening snap may be inaudible if the valve is heavily calcified. Yes, this is the point that we have to remember. Turbulent flow produces the characteristic low-pitched mid-diastolic murmur and sometimes a thrill. The murmur is accentuated by exercise and during atrial systole, pre-systolic accentuation. Early in the disease, a pre-systolic murmur may be the only auscultatory abnormality, but in the patients with symptoms, the murmur extends from opening snap to the first heart sound. Coexisting mitral regurgitation causes a pansystolic murmur that radiates towards the axilla. Pulmonary hypertension may ultimately lead to right ventricular hypertrophy, dilatation, secondary tricuspid regurg, which causes a systolic murmur and giant V wave in the venous pressure.